In this video we are going to discuss about fetal monitoring. So what is a screening test? This fetal monitoring we do only in a case of pregnant female who is having decreased fetal movements. So if any pregnant female is having decreased fetal movements, then only we will do for fetal monitoring. So among this fetal monitoring, the best fetal monitoring is modified biophysical score, which is you do NST plus AF5, that is amniotic fluid index. So we are going to do this NST and AF5, it is best in the case of modified biophysical score. Next, coming to second best is NST. Actually, what is this NST? NST is non-stress test. We call this test as non-stress test because here there are no uterine contractions in this period. So if we do the same test in the during labor, then at that time there will be uterine contractions. So that is called as another name I'll say about that. So first you need to see that in a pregnant female, if there are decreased fetal movements, the best test to do is modified biophysical score. In that you will do the non-stress test and amniotic fluid index. The second best test is non-stress test. And what is a diagnostic test? Diagnostic test is biophysical score, or also called as BPS. So this is an introduction part. Now let us see in detail what is non-stress test, that is NST in short. Okay, non-stress test is useful to evaluate the fetal heart rate especially in antenatal period. So in antenatal period, if you want to know the fetal heart rate, especially in a graphical manner, then you do this test. Okay, so next we have another test called as cardiotocography. So cardiotocography is actually NST, but another form of NST, where you do this in the during the period of uterine contractions, that is in intrapartum period, when uterine contractions are seen. So this is very important. NST means it is a fetal heart rate which you see on an antenatal period in a graphical manner. Cardiotocography means it is the same NST test but which you do in intrapartum, that is at the time where there are uterine contractions. At that time then you got cardiotocography. Okay, now coming to the two graphs. There are two graphs you can see on the cardiotocography. The one is fetal heart rate. In the upper part you will see the fetal heart rate, and in the lower part you will see the uterine contractions. So for example, if I try to draw this cardiotocography, here on the upper part like this there will be fetal heart rate, and in the lower part like this you will have uterine contraction. So this is a graph paper. So like this, two sides you will have the two graphs, one is of heart rate, fetal heart rate, one is of uterine contractions. But in the case of non-stress test, you will have a single piece of paper and you will have only fetal heart rate like this. So this thing you need to observe the difference between two. So NST or CTG both are same, but NST you do in the beginning point, CTG you do in the late point when there are uterine contractions. Now coming to components of NST. So components of NST, fetal heart rate is equal to 110 to 160 BPM, beats per minute. Okay, if less than 110 you call it as bradycardia, and if greater than 160 this is tachycardia. Okay, so less than 110 bradycardia, it is a marker of fetal distress. So in this graph we will also see beat to beat variability. The second point which you need to see is beat to beat variability. So what is this? it is actually here the FHR, that is fetal heart rate, is not constant in beat to beat variability, and beat to beat variability is of course a good sign. So fetal heart should not be constant, like it should not be like a straight line, it should have some variability. That variability is a good sign, that means the fetus is healthy. Okay, normal beat to beat variability, it should be like about 5 to 25 beats per minute. So this much of variability should be present. So if there is variability is absent, if the variability is absent, then, or you can say it is less than 5 beats per minute, then it is a marker of again fetal distress. So these are some of the important points which we need to keep in mind. Now coming to sinusoid wave pattern. So sinusoid wave pattern indicates fetal anemia. So sometimes if in the case of fetal anemia you'll have sinusoidal wave pattern, and this type of wave pattern is especially seen in vasa previa, twin to twin transfusion syndrome, RH negative female. Okay, or you can say RH isoimmunization. So now what is the management in the case of this sinusoidal wave pattern? The management is immediate termination of pregnancy, or you can do emergency C-section. Okay, so because this is a fetal anemia case especially seen in vasa previa, twin to twin transfusion syndrome, RH negativity, so it's better to immediately terminate the pregnancy. Now coming to another test which you do is fetal heart rate acceleration. So what is this acceleration? When the fetal movement occurs, okay, when the fetus is moving, there is increased FSH, increased fetal heart rate by 15 beat per minute into 15 seconds. So actually it should increase. This is also a good sign. Okay, then it denotes a healthy fetus. So know that important component in NST is fetal heart rate acceleration. So this acceleration is an important point in a non-stress test. So first what we do here in the patient, first we'll say the patient to go in the left lateral position. Okay, and this test is performed for 20 minutes, and here the fetal movements are noted, and also the mother will push a button on belt during each movement. So when the mother is moving this button on the belt for each movement, then the arrow appears in a graph. This type of arrow appears on CTG graph, and in a period of 20 minutes, if the accelerations are greater than or equal to 2 accelerations, then the NST, you can say it's a reactive NST, and the fetus is very healthy in this case. Okay, and if this acceleration is less than 2 acceleration, then again we'll directly not say the fetus is not healthy, but we'll repeat again NST for another 20 minutes. That is, you can take this test for about like 40 minutes, because 20 minutes before and 20 minutes now, right? So then you will say this is a non-reactive CTG. Even after another 20 minutes, still NST is not active. Alright, so next we will also go for biophysical score to confirm this. Even now we will not immediately terminate pregnancy, we will do biophysical score. So what is this biophysical score actually? Let us see. There is a term called modified biophysical score. Okay, so here in the modified biophysical score, we will do non-stress test. Along with it, you will have the amniotic fluid index. Just you will add amniotic fluid index. Okay, so NST represents the acute distress in fetus, and AFI represents the chronic distress of fetus. So this is the acute distress of fetus. This is a chronic distress of fetus. That is the thing we need to observe. So if any pattern is abnormal, Okay, so if any parameter is abnormal, the biophysical score will do the biophysical score. So NSD is done in all high risk pregnancies above 32 weeks. So all high risk pregnancies greater than 32 weeks, so regularly we need to do NSD. Okay, and so remember that in any abnormal case we'll come for this biophysical score, and NSD is done especially in high risk pregnancy above 32 weeks. And normal fetal movements. So first we need to understand what is normal fetal movements, right? So 10 movements in 2 hours of rest. So if the pregnant female is in rest, then at least 10 movements should be there, and 10 movements in 12 hours of activity. So whenever the female is in activity, then also there should be 10. So if sometimes if less than 10 movements occur, then the female should immediately come to the hospital, because daily fetal movement count should be always in count for the mother. Mother should be counting from the 3rd trimester. She should count daily fetal movements, and any abnormality if she finds, she should immediately come and consult the doctor. Okay, so remember, from 3rd trimester mother should start counting the daily fetal movements. So now let us discuss some detail about CTG, that is cardiotocography. So it is an intrapartum fetal monitoring, intrapartum, not antepartum. Okay, intrapartum fetal monitoring. When uterus contracts, pressure increases. So uterus contracts, pressure increases in the uterus. As the pressure increases, volume is inversely proportional. So volume of blood which is going to the fetus decreases. So sometimes if the healthy fetus is present, then that healthy fetus tolerates this decreased blood flow. Okay, so there will be no change in fetal heart rate. But sometimes in unhealthy fetus, it is compromised, it can't tolerate, and the fetal heart rate drops. So here the fetal heart rate will be normal because it has tolerated, but some will not tolerate. Fetal heart rate will drop. This drop is called as fetal heart rate deceleration. Okay, so fetal heart rate deceleration is a dip. It's also called as dip by 15 beats per minute for 15 seconds, and it is mostly pathological. So this is considered to be pathological. Now let us understand this by means of a diagram. Okay, so first we will see what are types of decelerations, and next we'll understand this by diagrams. So what are the different types of decelerations? So first one is early deceleration. So it is mainly due to head compression, which is physiological. When the uterine contracts, the head compresses when coming out, especially during labor. Okay, and that is physiological. Okay, head compression is physiological. Onset of dip should coincide with the onset of uterine contraction. So for example, you see this is the dip here. Okay, and this is the uterine contraction. So this is a dip, this is uterine contraction. So you can see here, this is the onset of dip here. Onset of dip should coincide with the onset of uterine contraction, you can see here. Okay, and next, the end of the dip in the fetal heart rate end along with the uterus contraction. You can see the end also similar, almost similar, right? And the gradual dip should be greater than 30 seconds. The time from onset of dip and the peak of the dip should be less than 30 seconds. This is the peak of the dip. You can see this peak lower point of the dip is equal to the peak of upper point of the uterine contractions, right? So these are all similar. And remember that the gradual dip greater than or equal to 30 seconds. Okay, time from onset of dip and the peak of the dip also greater than or equal to 30 seconds. Okay, so what is the management here? Just wait and watch. Okay, the gradual dip, the time from the onset of dip and the peak of the dip. So from the onset of dip and the peak of the dip, this time period here should be greater than or equal to 30 seconds. Gradual dip greater than 30 seconds, peak of dip. So the distance from the this onset of dip to the peak of the dip, this is called as gradual dip. Okay, and next coming to late deceleration. Late deceleration is where it is mainly caused due to uteroplacental insufficiency, and it is most ominous type of deceleration. And here actually the problem is the onset of dip in fetal heart rate after the beginning of contraction. Okay, and you can see here so these are uterine contractions and this is the dips here. Okay, about fetal heart rate, right? So you can see here this is beginning, but still here it's not beginning. Here already the peak has come, but here the peak is, you can see they're late. So this is late deceleration, the onset of dip in the fetal heart rate after the beginning of contraction. And in the nadir, this is called nadir, the nadir of deceleration and the peak of contraction do not coincide, and the nadir of fetal heart rate dip is later than the peak of contraction. You can see here clearly, right? So they are late, that's why late deceleration. So the end point a fetal heart rate dip, you can see here fetal heart rate dip endpoint does not end with uterine contraction. So dip is gradual, so your fetal heart rate dip is gradual, and this is also greater than or equal to 30 seconds. Now what is the management in the late deceleration? So here the management is PT in left lateral position, put the patient on left lateral position, give IV fluids and also give oxygen, and stop uterotonic drugs. If persists, then it is an indication for C-section. Okay, so early deceleration just to wait and watch, but for late deceleration do the C-section. Of course here first you try for putting on patient on left lateral position, give IV, give oxygen and stop uterotonic drugs. Even though still it persists, then it is an indication for C-section. Okay, and about variable deceleration and other parts we'll discuss maybe in another video. Okay.